issues. Anybody who's not familiar with Emma Brockwell, then part of the recent guidelines for return to running postnatal with Gráinne Donnelly and Tom Goom, and it's a big one because there wasn't really, as I'm sure we will hear soon, there wasn't anything beforehand. It was like this area which no one talked about, and as we're going to hear, I'm sure it's an area where we definitely need to talk about, with no pun on area, but it fits both physically and verbally as an area we need to talk about. So thanks, Emma, for joining us, and I'll hand over to you.
Thanks, Matt. Before I start, I just wanted to say thank you to you, because I know how much hard work this has been, and I think it's amazing that you've put it together given the situation that we're all in. And also thank you for letting me speak about pelvic health, because it's not necessarily a topic you'd align with running. Hopefully I can change that with this talk. But you've given me a platform to talk about something I'm really passionate about, and lots of us are really passionate about, and so thank you. I really appreciate it. So good morning, buenos dias. I hope you're impressed by that, because that's about as far as my Spanish goes. Thank you for all having me today to talk to you about returning to running postnatal. Over the past 15 years, I think we'd all agree that the popularity of running has grown dramatically. For the first time in history, there are finally more female runners than there are male runners. And running's popularity can really be attributed to a number of things, including the fact that it's free and it's accessible. I carried out an Instagram Q&A and just asked women a few weeks ago to use one word that would describe why they love to run. And the overwhelmingly popular word that came up time and time again was freedom. I'd agree. I do think running is freedom. It's an opportunity for some well-earned headspace. The benefits of running, I'm sure, add to its popularity. Rowe et al. Carried out a review that highlighted the many benefits of running, which include improving mood and cognition, improving fertility, improving the immune system and muscle strength, and preventing hypertension. More female runners mean that more women are continuing their running routines through pregnancy, the postnatal period, and beyond. However, when some women return to running postnatally, they're hitting many physical hurdles. For example, musculoskeletal pain, urinary incontinence, abdominal separation, and pelvic organ prolapse, which they'll either just put up with, or in many cases, these conditions can lead to a withdrawal of exercise and fitness activities. Pelvic floor dysfunction is common, but it is not normal. 1 in 3 women will experience urinary incontinence after having a baby. 1 in 5 will suffer from fecal incontinence after having a baby. 50% of women after a vaginal delivery and a cesarean will lose some sort of pelvic organ support, which can then lead to a pelvic organ prolapse. In the summer, Gráinne Donnelly, who's my co-author of one of my co-authors of the running guidelines, and I had the privilege of working alongside Dr. Izzy Moore and her team to look into some of the factors which may affect the return to run postnatally. Izzy and Megan James designed a questionnaire to help us determine this. 903 female runners within 2 years of childbirth answered our questionnaire, and preliminary findings showed that 26% had not yet returned to running for 2 predominant reasons: fear of movement and vaginal heaviness. As healthcare, fitness, medical professionals, running coaches, we need to ensure that we don't lose women to running because of such physical symptoms, and that we're addressing the often stigmatised and taboo conditions that can affect any female runner. Let's step away from the postnatal and running population for just a moment. Pelvic floor dysfunction can affect any woman at any stage in life. Interestingly, the prevalence of urinary incontinence ranges from about 28 to 80% in young, nulliparous female athletes, with the highest prevalence in high-impact sportswomen. Research done by the likes of Dabrowski, Carvello, and Rodriguez-Lopez shows the prevalence of stress urinary incontinence amongst this population. Athletes do withdraw from their favourite sports because of stress urinary incontinence, and a large proportion that continue to exercise will practice their sport in a limited way. This can have a really negative impact on their performance. Athletes may experience feelings of concern and frustration that urinary leakage might be noticed by their peers. So it's clear that it's not just within the population of postnatal runners that pelvic health should be considered, screened and improved. Pelvic health has to be considered for all women, regardless of their childbearing or athletic status. So why aren't some women returning back to running postnatally safely and effectively? The reasons are multifactorial. Incontinence pad companies are notorious for poor messaging. Their adverts still try and normalise or even sensationalise urinary leakage, for example, and they encourage women to simply manage their symptoms with pad usage rather than seek treatment. There's a considerable amount of stigma and taboo surrounding pelvic floor dysfunction. Women are too embarrassed to admit that they have these symptoms, and so they don't seek help. Historically, women have been led also to believe that their symptoms like urinary leakage are normal and just part of having had a baby. It takes up to 7 years for women to seek help for symptoms of pelvic health, partly due to embarrassment and partly because women believe it to be their new norm. We need to tell women that it's common, but it's not normal to suffer from pelvic floor dysfunction and that treatment exists. And women need to stop accepting these symptoms as their new norm. There is very little evidence around returning to exercise postnatally. Little evidence brings with it little official guidance for a return to exercise, which poses many problems. It's a topic that's still underestimated and misunderstood in today's health and fitness world. Much of the information that does exist is misleading. Clinicians, fitness professionals, running coaches aren't always sure when the best time to return a woman to running is, and specialities are still segregated, which prevents a consistent information pathway and creates a considerable amount of conflicting and confusing information for a woman wishing to return to running. Currently, the only real tick box that exists for a return to exercise postnatally is a 6-week GP check. And really, this just exists for litigation purposes. GPs simply do not have the time to carry out a thorough examination to determine a woman's return to exercise status. And the 6-week mark really only considers the healing and recovery of the smooth muscle of the uterus and perineal or surgical incision healing. The healing process, as we'll talk about, extends well beyond this, and it's essential that the narrative on this subject changes and better adapts to serve our sporting women. There's huge pressure nowadays to get back into shape as well and lose weight after having a baby. And women see running as a simple, cheap and effective way of doing this, often rushing to return before their body is ready. Women do have an unrealistic expectation, which is often exacerbated by media that portrays the bounce back as the norm. And again, this places huge unjustified pressures on women. Pressures do extend into the elite sporting world. There are many sponsorship, career and performance pressures which force an athlete back into running too soon. Alicia Montana has been really vocal about these pressures, as she's going to just talk about over the next minute and a half.
Emma?
Yeah.
The sound of your video didn't appear, but I think you need to share again with sound. Share again your screen.
Oh, it's not working?
Yes, share your screen again with sound active. Yes, no problem.
Sorry. I've been sitting having a nice sip of cup of tea there. What do I need to do, Maro?
Escape, stop the sharing.
Yeah, sorry guys.
Don't worry, and share your screen again and check the box that say that
I'm with you.
Share your sound. Huh?
I've got 100% sound, I'm not sure why.
It's okay. It's a typical problem. Don't worry.
Oh, your calming work voice. Now, is that sharing anything for you at the moment?
Is your screen without presentation? That's it.
Okay.
But
give me 1 second. Oh, no.
Don't worry.
Okay. Did you hear any of it?
No.
Oh,
Not yet, but put play in your video, please.
okay.
Press play. No.
How's it? Is that working?
No, not working. But stop your share screen. You share a screen, stop it.
Yeah.
Okay, and share again. And you will see in this share box a little box below that allows you share your sound of your computer. In the left
Oh, yes,
corner.
I see it. Yeah.
Yeah, that is.
Ah, sorry, Mauro. Okay.
Don't worry.
Oh, man. Right.
This is my job.
Oh, well,
Okay.
Sorry. Okay, so I'm going to go again. I do apologize. So, how's
I'm
that?
Alicia Montano.
Perfect.
I'm an Olympian. I'm a national champion. And I've been one of the top 3 runners in the entire world. And I'm a mother. When I was pregnant with Linnea, I kept training. I even ran in a big race, and it was a pretty big deal. They called me the pregnant runner. And I wanted to show people that you can be a mother and still have a successful career, even in sports. I was sponsored by Nike, and then when I told them that I wanted to have a baby during my career, they told me, simple, we'll just pause your contract and stop paying you. And we're not just up against our sponsors. The U.S. Olympic Committee strips our health insurance if we do not stay at the top of our game during our pregnancy. And this just makes our comeback even harder. I had my daughter, and when I was on my return and trying to recover from my pregnancy, they also threatened to stop paying me. I was pissed. I was very upset at the fact that there was not a policy in place that would protect me. And I fought tooth and nail to make sure that this would not happen to other women. I started a maternity leave legislation so we would not lose our health insurance. I taped my abs together because they were torn apart. I wore a brace as I'd go and I'd lift to come back within their time frame that they were expected of me. They weren't sure if I was going to be able to return after my pregnancy. I showed up to the World Championships in Beijing, China, still nursing my daughter and pumped for 10 days so that I can ship my milk back to my daughter in the States. So companies like Nike tell us to dream crazy. Then they tell us to believe in something. We say, how about maternity leave? How about when you tell my daughter she can achieve anything, you back it up?
Apologies for that, guys, but I hope you felt her words were worth listening to. She's certainly someone worth following on Twitter and Instagram. She's an incredible woman. Mara, can you hear me okay now? Am I good?
Yes, all good, Emma.
Perfect.
Don't worry.
So as you've heard, athletes have to return earlier than their bodies are ready for to fulfill contractual agreements, and often this can have detrimental effects on their health. This very public fast return to elite sport is noted by the average woman, who then feels even more justified in trying to return sooner than they're ready for. The IOC expert group acknowledged that there was little evidence on athletes returning to exercise and competition after childbirth. Since research is limited, the IOC based their consensus statement for elite athletes returning to exercise around studies on physically fit soldiers. Vayner et al. Found that only 19% of female soldiers were back to their pre-pregnancy fitness at 6 months postnatal. The majority required a full year to return to their pre-pregnancy fitness. The IOC concluded that postnatal resumption of physical activity is an individualised process, and that all postpartum women have a degree of deconditioning regardless of previous fitness, and a graded return to exercise is needed. For all of these reasons, Gráinne Donnelly, Tom Goom and I decided to write our Return to Running Postnatal Guidelines. The aims of our guidelines are to be accessible, evidence-based, suitable for all health, medical, fitness professionals and running coaches, and have a preventative approach to pelvic health. In April this year, the infographic Guidance for Medical, Health and Fitness Professionals to Support Women in Returning to Running Postnatally was published in the BJSM. This team collaboration between Donnelly et al. Summarises the guidelines, and it aligns with the Chief Medical Officer's physical activity infographics for pregnant and postnatal women. I now want to discuss with you some key points from the guidelines, so that if you're a female runner listening right now, you can have a clearer idea as to how and why you should be, what you should be considering when returning to running postnatally. And if you're a healthcare, medical, fitness professional, running coach, I want to be able to make you more aware of the key points which may help you guide your female runners back to running more successfully. We're all familiar with the importance of injury, recovery and rehabilitation, including optimal loading at optimal timeframes. We wouldn't consider returning a footballer to play following a grade 2 ligament sprain or an ACL injury until they had made appropriate progression through rehabilitation, satisfied specific return to play criteria, and were assessed to be match ready. Why then do we not consider the huge physical and mental implications that pregnancy and childbirth impart on a woman prior to giving the thumbs up to exercise? Recovery of the pelvic floor muscle, its associated connective tissue and nerves, is generally maximised by around 4 to 6 months, which is well beyond the traditional concept of full recovery by the 6-week postnatal check. To reinforce this, if we consider caesarean section deliveries, we understand that abdominal fascia has only regained just over 50% of its original tensile strength by 6 weeks post-abdominal surgery, and 73 to 93% of its original tensile strength by 6 to 7 months. Work by 𝐑𝐮𝐧𝐬𝐿 et al. In 2018 adds to this. They found that postpartum women had large deficits in trunk flexor strength, fatigability and steadiness of contraction up to 6 months postpartum, and women who had delivered by C-section had even greater deficits in fatigability than those who had had a vaginal delivery. This study supports the fact, excuse me, or it supports the need for skilled assessment of the musculoskeletal system by healthcare providers who have expertise in the examination, diagnosis and treatment of musculoskeletal disorders. So it makes sense to consider sensible progressive rehab in the very early days. Consistent with musculoskeletal literature on other conditions, recovery typically encompasses the first 12 weeks after childbirth. But to be clear, 12 weeks is not prescriptive and requires clinical reasoning. It's a guide. Following an uncomplicated pregnancy, for example, and uncomplicated childbirth and recovery, women may progress to a return to run in less than 12 weeks. But in contrast, women who experience complications may be in the recovery phase for longer than 12 weeks. So it's important not to tie progression to a specific time frame, but rather to be specific to individual presentation and symptoms. There are key signs and symptoms that indicate a woman is not yet ready to return to run. These include leaking urine or feces, heaviness, dragging in the pelvic area, pain with intercourse, obstructive defecation, abdominal separation, which compromises abdominal function, and lumbopelvic pain. A key recommendation for our guidelines is that every woman has a pelvic floor screen for the simple reason that the pelvic floor, regardless of delivery, has the potential to be stressed, weakened and traumatized during pregnancy and childbirth. An adequate evaluation of strength, endurance, as well as structural support post-baby is essential. Strength and endurance can be assessed via an internal assessment using the modified Oxford score, and it's tested in both crip lying and functional positions, for example, standing. When considering the structural support, we recommend that the GH plus PB component of the POP-Q evaluation is used. So really, for the sake of interest and for those who are specialised in this area, the GH plus PB measurement is as follows. The GH, or the genital hiatus, is the distance between the urethral meatus and the posterior fourchette. Second measurement is the perineal body, or PB, and is measured from the posterior fourchette to the anterior anus. A collective measurement of more than 7 centimetres on Valsalva, which is bearing down for 6 to 8 seconds, is highly predictive of apical support loss, and the clinician should then be considering that they advise the women to potentially use pessaries for further support. Key load and impact management testing is outlined in the guidelines too, to expose a postnatal woman to high impact exercise and monitor for signs and symptoms of musculoskeletal and or pelvic floor dysfunction. In order to successfully complete the load and impact assessment, the postnatal mother needs to achieve the load and impact testing without pain, heaviness in the vagina or dragging in the vagina, or urinary or fecal incontinence. The strength tests are based on testing key muscle groups that manage high levels of loading during running. Performing these tests allows us to approximate how likely someone will be to manage a return to running at this stage. These tests don't necessarily rule out a return to run, but they certainly help us assess what rehab needs that woman might likely have. Women who want to run postnatally aren't often delighted when they're told that they can't yet return to running. So as therapists and coaches, we have to look at ways in the early days to maximise training and minimise load. I personally like getting women to start fast walking on an incline. If you have an autogy in the clinic, that's an amazing tool to use. The stair mill, reformer push boards are always to look at doing just this and providing variety in a women's programme, which are still fairly run or sport specific. The introduction and progression of low impact and low level load is encouraged even as early as the first 0 to 6 weeks post-baby. Concerns have been raised in the past that starting exercise early in the postnatal period may negatively impact on the already stretched and weakened pelvic floor muscles. In April 2020, 𝐂𝐸 et al. Published their paper that looked at the influence of early exercise postpartum on pelvic floor muscle function and prevalence of pelvic floor dysfunction 12 months postpartum. Their findings suggest that regular general exercise performed at 6 weeks postpartum didn't negatively affect the pelvic floor muscle or increase the risk of symptoms like stress urinary incontinence or pelvic organ prolapse 12 months postnatally. This aligns with the work by 𝐸𝐮𝐬𝐻 et al. We need to consider that the pelvic floor complex and abdominal wall are structures or tissues. To improve the capacity for tissues to adapt, you need to gradually increase the load, particularly in the early days of rehab. If the load is increased too fast relative to load capacity, then we could increase injury. Celeste Goodson here demonstrates this concept beautifully. Celeste is the postnatal fitness professional that's worked with Alicia Montana, who we just saw or heard speak, and Alison Felix, and she's guided their return to run postnatally with their pelvic health in mind. These athletes have gone back to running with huge success. Here she's demonstrating some of the rehab options and loading that she offers her new mums as they prepare their abdominal and pelvic floor muscles for high impact, with a consideration of developing the strength and function of these muscles, their pelvic stability, their lower limb strength, and pelvic floor responsiveness with low impact running. As we near the latter stages of recovery and rehab, there are lots of things that we can still be doing that are run specific and motivate our patients while considering still a gradual increase again in load. It's worth considering breaking down sprint drills, considering variables like surface, which could be soft to hard, speed, slow to fast, duration, short to long, and impact, low to high. This video has no sound, but it does go on for a little bit, but she does use some good examples. If the woman is symptom-free, passing all suggested tests, a graded return to run, like the Couch to 5K programme, can be introduced. Once the programme is complete, run training progression should consider changing one thing at a time to avoid training error injury. For example, building training volume prior to increasing training intensity could be recommended. Of course, like any other injury or recovery approach, healing after pregnancy and childbirth requires a holistic approach. There are a multitude of factors that play an important role in a woman's recovery, which include sleep, nutrition, breastfeeding, weight, and psychological status, a few of which I'll just discuss now. The risk of a postnatal mother developing relative energy deficiency in sport, or REDS, should not be overlooked. REDS, formerly known as the female athlete triad, refers to an energy deficiency relative to the balance between dietary energy intake and the energy expenditure required to support homeostasis, health, and the activities of daily living, growth, and sport. It affects many aspects of physiological function, including metabolic rate, menstrual function, bone health, immunity, protein synthesis, cardiovascular, and psychological health. With the lifestyle change that a new mother faces, which includes sleep deprivation, lack of routine, demands of breastfeeding, and the potential to alter eating habits, it isn't hard to foresee how an energy deficiency may occur. On top of that, many sporting athletes feel pressured to get back into training and return to their prenatal physique, which may further influence choices predisposing risk factors to REDS. Postnatal women with REDS are at an increased risk of stress fracture, pelvic floor dysfunction, and potential fertility issues later in life. It's likely that women embarking on returning to running are still breastfeeding. It's recognised that breastfeeding prolongs the presence of a hormonally altered environment in the postnatal mother, with lower levels of estrogen and the possibility for slightly raised levels of relaxin to continue. Theories that higher relaxin levels postnatally increase the risk of joint laxity and potential injury have not yet been proven. It's not fully understood why some breastfeeding women may have increased joint laxity compared to baseline. However, it's recognised that the overall environment of hormones during this period of time and up to 3 months following weaning may influence joint laxity. This in turn may increase the mother's risk of developing injury or dysfunction, increasing pelvic floor dysfunction. It is important to establish whether any pre-existing joint mobility existed prior to pregnancy and whether the environment that breastfeeding created is significantly exacerbating this. It's recommended that consideration of breastfeeding status is given to a postnatal mother throughout the process of her evaluation for return to running. Education should be provided about timings of feedings and also about bra wear, supportive wear, alongside may have a role in management. Yeah, basically just to make sure that we're supporting and encouraging better breast wear, and also encouraging women to feed before they go for a run. The key recommendations of our guidelines are, in summary, that all postnatal women, regardless of delivery mode, should be assessed by a pelvic health physiotherapist prior to returning to high impact sport. Any signs or symptoms of pelvic floor dysfunction indicate further or ongoing assessment and management prior to continuing and progressing training. Key load and impact management testing is outlined in the guidance to expose a postnatal woman to high impact exercise and monitor for signs and symptoms of musculoskeletal and or pelvic floor dysfunction. And finally, additional factors should be considered when guiding a woman back to running. In 2016, 𝐷𝐮𝐻 et al. Presented a great consensus statement to make recommendations for returning to sport decision making. It was agreed, using the current evidence at the time, that return to sport should be viewed as a continuum, paralleled with recovery and rehab. We need to consider a return to run postnatal in the same way that we might consider a return to play. And I think that you can see, if we modify this framework slightly, that this approach applies to pelvic health as an inclusive return to play strategy. Exercise is important to maternal health and well-being, yet evidence related to musculoskeletal and pelvic health and safe return to exercise after childbirth is limited, with an even greater dearth of knowledge regarding safe return to high-intensity exercise and competitive sports. Research is sorely needed to determine the best way to provide comprehensive postpartum care and return to sport in an effective and responsible manner. In closing, returning a woman to running requires careful screening, consideration and rehabilitation. Further research and promotion of the impact of pelvic health is required. Our guidelines encourage health and fitness professionals to work together across the traditional boundaries and specialisms to give a more holistic approach to postnatal recovery. With this holistic approach, we hope that not only is any pelvic floor dysfunction or musculoskeletal system addressed, but also prevented, which is an essential factor in the world of medicine today. Every woman's return to running will vary and should be individualised. We always like to encourage further discussion around this subject, and we have a Facebook group which you can hopefully see here. So we would encourage you to join us. We update it regularly with the latest evidence, and of course if you have any problem patients, so long as it's anonymised, we'd encourage you to come along and discuss it on that forum. The tests that we illustrate within the guidelines can be found on our YouTube channel. And Athletics Northern Ireland have really embraced the guidelines, and within their website they've developed some videos that again depict how they start returning women back to running postnatally. So thank you, muchas gracias. Apologies for the lack of pronunciation. And of course, if you wish to get in touch with me, here are all the ways you can contact me via Instagram, Twitter or Facebook. And I'm sorry for the video mess up.
That's brilliant, Emma. Thank you so much for testing our video sound. We needed somebody and it worked well. So
Great.
Thank you for testing that.
That totally threw me.
That was great. No, thank you so much, and coming back so professionally. And Mara,
just about.
Oh, Mara, I think I've fallen in love with you a little bit more even.
I definitely have. You kept me calm. Thank you. I was freaking out internally.
Don't worry.
That was great.
I am used to that. Don't worry.
Brilliant, Emma. Thank you so much. I've tweeted and Facebooked out some of that because it's such an important area, isn't it? And like you say, it's just typical that it has been avoided, but it needs to be considered the same as any other part of the body which we consider when working with a runner. And yet it hasn't. So it's brilliant. Yeah. We've got some questions. We'll do the same thing, people. If you want to switch your cams on, then you're welcome to. I know we've got some questions lined up. So maybe, I think it was Becky. There we are. Let's give Becky the power. Ask to unmute. I've just muted her again. Sorry, Becky.
There's tension.
I think we were both pressing buttons at the same time.
Hi, Becky.
Hi, Emma. That was amazing. Thank you so much. And thank you for addressing that subject. It's so important. Just a quick question. I wonder how you would like to see coverage of women that have been able to return to work, running successfully quite soon postnatally. I'm thinking of people like Sophie Power. How would you like to see coverage of them balanced so that we hear their stories, but we're not putting undue pressure on women for whom it might take a little bit longer?
Oh, good question. Yeah, it's a difficult one, isn't it? Because some of the likes of Sophie, she's complex in the fact that and I think it's very well known, not very well known, but it's known that I'm her physio, her pelvic health physio. She's put that on her social media. Sophie's complex in the fact that she will return to running regardless of what is said to a large extent. What I love about her approach is that she has embraced pelvic health physio, and she has very much pulled back, much more than she wants to, during her pregnancy and in her last postnatal recovery. What I think she does really well is state that she is probably returning back to running sooner than the average woman. And Alicia Montana has said the same, Stephanie Bruce has said the same. And I think it's just really important that they're acknowledging that they are returning back to running with good pelvic floor management. But what they do that's probably different to what a lot of women do is they put in hours and hours and hours of time with their rehabilitation. And so yes, they do return sooner, but so long as they're adding that caveat of, but we rehab considerably and we are asking more and more demands of our bodies than the average woman. However, their return to run isn't it's realistic, but it's realistic for the effort they put in. So I just think within the media there needs to be more coverage of what pelvic health physios do, and all of these women are having pelvic health physio, and that in itself would be amazing, just for actually our job titles to spring up every now and then, and that these women are saying that they're not doing it on their own, they are having the support that's required. So I don't even know if I actually answered your question there.
No, you did. That's perfect.
I think we just need more promotion of pelvic health physio within what they're doing, and acknowledgement of how much work they put into their pelvic health as well now.
That's brilliant. Thank you, Emma.
Okay, great question. Thanks for that. Shane Robinson has got a question. I've just got to find Shane in this list of
I can see his picture. Oh yeah.
Where?
I think he's on there. Oh yeah, I'll probably have a different page to you, do I? Page 1.
Oh, there he is. Sorry, Shane. I'm going to unmute you now. How are you, Shane? How you doing?
Hello, I'm good. Can you hear me?
Yeah, you're good. Far away.
Hi,
awesome.
Shane.
Yeah, so this may be covered under the sort of return to sport thing as well, but for some athletes, some women, obviously, hard training is their outlet. So where do you put in, say, in the progression, a low impact but high intensity training session? The example I use is something like a watt bike or a turbo session. You know, from the point of view of the athletes who need these sessions as an outlet, when do you put those in, or how, when and if do we hold these people back?
Yeah, I think you put them in when they are reporting any signs of pelvic floor dysfunction, and we try and encourage that low impact work like the watt bike or spinning come in at around about 6 to 8 weeks postnatally. Saying that, I have one elite athlete at the moment, and we've introduced that at 5 weeks because her body's ready for it. I've tested her pelvic floor strength. She has no signs of pelvic floor dysfunction, so it's just a case of screening. Is she flagging anything at the moment? No, great. So then we can push the intensity in a low impact way, and then carry on evaluating and ensuring that we're consistently screening whilst she's increasing the intensity. But I'm really keen that they do increase their intensity, but in a lower impact fashion.
Okay, thank you.
Thanks.
Okay, what else we got going on? The questions are flying through here. First of all, I've just noticed here, yeah, Emma Bergen-Kisby said, brilliant, thank you so much, Emma. Looking forward to the book.
Oh.
So modest. I have to price this information out of the speakers I choose because I love modest people. So Emma, yeah, tell us about the book.
Oh God. Yeah, so I've written a book for women to help improve or make awareness of their pelvic health during pregnancy, childbirth and beyond. So it's kind of giving them the real truths of what to expect in a nicely packaged way, because the amount of women I see post-baby who just say, well, I didn't know I was going to leak urine, why the hell didn't anyone tell me? And I don't really know why we're not telling women these real facts, because we should be empowering women then that if they are suffering from the likes of leakage of urine or pelvic organ prolapse, that there's treatment out there, and the first line of treatment is generally pelvic health physiotherapy. So I hope it's a book that will help lots of women just know and understand more about their bodies in general.
Fantastic.
And it's out in February.
Thank you. That's the most important bit, out in February. Great stuff. Is that written, or I don't know, I'm just asking questions off my head. Is it going to be like an audible version? Is it going to be audio only as well, or?
I don't know. I think there's maybe plans, because it's published by Penguin, so they are pretty good at pushing the old audio and the marketing side of things. So
especially for runners always find it difficult to run whilst holding a book. It's just something doesn't work very well, so that's why they love audibles.
Doesn't work that well, does it?
No, I've seen one of them doing it. That was Brighton, so it's a long story. We've got a question here from Mike, which I'm just going to read out because it's a really good question, obviously. Mike asks, women's health issues can be a difficult subject for male therapists and female runners working together to deal with. How do you suggest male therapists / trainers and female runners can feel more comfortable working together?
We've had this discussion a few times, haven't we? I don't know the exact answer. I think using some sort of questionnaire can be really helpful. For me, it still amazes me that these things are a source of embarrassment, because you know, I understand why people don't want to say that they're leaking urine. What about men that leak urine? What about men that have pelvic floor dysfunction? Because men do have pelvic floor dysfunction. Let me flip that to Mike and say, how would he address that when he speaks to a male patient? Does that ever get addressed amongst male coaches or therapists? Because I do think women are more comfortable at having these conversations, but I wonder too if women in general are more comfortable having those conversations with men as well. And so it's about normalizing, isn't it? The more we talk about it, the less weird it sounds, the less taboo and the less stigma around it. So I think it's about talking more and more about it, and recognizing that you as a male therapist or coach are doing that patient or client of yours a huge service by asking them that question, because it could be that they're desperately wanting to tell someone, and you just having that conversation could make such difference to their performance and to their general physical and mental well-being.
Yeah, I think I mean, we talk about this in different associations like Sports Therapy Association, and I think a lot of it's just adding those questions and reevaluating the medical PAR-Q and having it on a sheet.
Yeah,
and like anything, some of those questions start off weird, but once you've asked them a few times, it just makes it normal. And
do you ask men if they have any pelvic floor issues?
When you said that, I mean, yeah, there should be a technical question on any medical PAR-Q. Do you have any problems going to the toilet, or any sensitivity issues around that area? Because we're looking obviously for red flags. So it does get covered, but it seems to be one. This is why I don't necessarily, I see disadvantages of just giving a questionnaire to someone to tick, because then you just scout down the page, you just see the ticks and you ignore stuff. I prefer, well, I can going through particular questions and asking them, because then it opens up a bit of dialogue rather than just tick. And
some people won't tick those boxes because they don't want to talk about it.
It works both ways, doesn't it? It's not just the therapist who's uncomfortable. It could be the patient as well, who's not too keen on opening up. So I think it's a part of a big society thing, isn't it? It's part of a taboo that we need to kind of break down a little bit. And
it is. And I think I used to be a musculoskeletal physio, and I definitely remember feeling a bit uncomfortable asking people those questions. Now you can't stop me asking those questions, and I'm really comfortable talking all things vaginas and vulvas. But that does take it's just practice, and I'd encourage you to do it, because I think you can make the world of difference to someone.
Fantastic. Right, I've got some hands up here. That function's working now. There should be hands up if you want to ask a question. Let's go over to Shwetha. I'll ask to unmute and fire away, Shwetha.
Hi, Shwetha.
Hi, Emma. I do follow you on Instagram and listen to your lives, and thoroughly enjoy and appreciate your great work that you're doing.
Thank you.
What I have observed with a lot of female physio runners is that when you do and work on their rehab, they're pretty okay, but when they go out running, sometimes if they have an urge to pass urine or pass stools, and they don't have the facility, they try to hold it a lot, and then somewhere, and then they kind of just lose it all. So how do you train them for this? Because then it feels like, you've educated them, but they've not, done the right things.
So they're experiencing urgency incontinence. Is that what you're saying?
Right. Yes, especially when they have long mileages.
Yes. So it's really hard to ask someone to run a very long distance, like the ultra runs, without expecting them to step behind a tree and pee. And I think I've done it before with some of my longer runs, and I don't think there's any harm in that. We should be peeing. God, Matt's face. We should be peeing every sort of 3 hours, 3 to 4 hours. And if you're running for longer than that, like someone like Sophie Power, she's quite comfortable with peeing behind a tree and cracking on. But for the girls who are getting urgency and needing to pee, let's say within 15 to 20 minutes of their run, then we should be teaching them some deferment techniques. And probably getting their pelvic floor assessed as well. Also addressing how much they're drinking and what they're drinking when they're running. Is anything like that aggravating them? Because some of the sugary drinks can be a real bladder irritant. Some women and men like to start their run with a coffee, and for some that's just too irritating. So it might just be a case of talking to them about adapting their fluids. And some runners don't drink enough, and actually, ironically, that can cause an increase in urgency as well. So I would definitely get them to keep a bladder diary when they're running, and have a look at not only what they're drinking, how much they're peeing, how often they're peeing, and then work on looking at some fluid alterations and also some deferment techniques, so they can start, just like any muscle, start gradually building up the hold of their pee when they're running. But it's quite a slow process, something like that. But again, I don't know, do you have access to pelvic health physios in India?
Yes, it's recently started.
Oh, great.
And we have a few of them. But it's really difficult because as such, sex and female health and whatever is such a taboo subject, Indian culture scenario. It's very, very difficult because it's a very sensitive topic. It's not spoken so much in our culture at all. It's still hush hush, so not probably in this millennial generation, they're pretty open, but generations like mine, or especially the 30-35 plus female runners who go through all these problems, it's very difficult. Just trying to build the awareness around here now. I have a female pelvic physio who works with me, so just trying to create that awareness. Oh,
amazing. I mean, that is there's cultural, there's cultural sensitivity there as well around what we're doing.
Yeah, it's a big culture.
I'm sure. But isn't it like all of these things? It's just about education and empowering, and ultimately that's what you're doing. You have a women's health physio there now, so I definitely work with her more. I'm happy to send you some of my bladder diaries that I would use as well, if that would be of any help. If you just drop me an email, I'll do that.
Right. Sure. Definitely. Thank you so much.
Okay. Cool.
Fantastic. Right, people. Sorry, those of you who were waiting to ask a question, but I'm going to try and keep it quite strict, otherwise we're going to run over. Bear in mind that if you do have more questions for Emma and things crop up, then Emma will be around in the Q&A sessions today, tomorrow. Emma, what's it looking like?
Today, definitely. Tomorrow, the kids I'm going to put them in front of a movie and hope for the best.
Well, today, definitely. Okay. So yeah, if you think of any other questions, then because it's not just, it'd be interesting to open up questions about women's health to all of our 10 speakers. Obviously, we've got other women there as well, but also the male therapists will be able to contribute. So yeah, if you do want to send pre-questions for our Q&A session this afternoon with all 10 speakers, then again, send them to me privately or tomorrow, and then we can start logging them up and giving speakers. Right, Emma, thank you so much. Same question to you. What have you got? I mean, it's a bit of a weird question with all the COVID and that, but plans for the rest of the year?
Yeah, so we've got Therapy Live. We're interviewing someone on Therapy Live. The Jacks have roped us in again. They're good at that, aren't they? And then I've got CSP. I'm doing a talk about the guidelines there with Nicola Brown and 𝐂𝐨𝐬𝐿𝐼𝐳𝐼𝐳𝐼. And trying to keep clinic open, really, because it's all a bit crazy, isn't it? And who knows? So just taking one day at a time and hoping that we carry on without a lockdown, which I know some people are in, but I'm lucky in Surrey not to be in it yet. So hopefully it remains that way.
Do you see, because obviously you're in touch with it more than anyone else, is there a little bit of an exciting buzz about this subject, which obviously you've worked in for years, starting to gather a bit of traction, people talking about things more? Is it kind of satisfying for you?
Yeah, it's amazing because more athletes talking about it, and there's a huge interest in my social media world. There seems to be a huge interest, and I think women are getting more empowered and more educated on the subject, and realise that they don't have to jump on the trampoline after having a baby and leak urine. So it's an incredibly exciting time, and there's definitely a hunger for more knowledge around it. We just need more research, and Dr. Izzy Moore, who I think is here somewhere, she has really embraced the pelvic health side of things. So thanks, Izzy, because she's working with me and Grania a little bit now, and it's been a real honor. And incredible to see someone of her caliber doing some more research around the subject. So I think exciting times are to come, definitely.
Yeah, Izzy's going to be joining us in the lunchtime break as well, people. So if you've heard of, if you haven't heard yet, then check her out. But definitely when it comes to research and running, it's kind of like synonymous. They go together. Right, Emma, thank you so much. I appreciate it. And we'll speak to you later on. Right, people, it's 11:36. At 11:45, we have the beauty that is Mr. Ben Cormack coming up to talk about, he loves it when people call him beautiful, to talk about movement variability. For those of you who don't know Ben, I mean, it really is a pleasure and an honor to have him talking with us today. Been on the scene for a long time now. San Diego Pain Summit just finished for this year, but he was one of the original speakers there. A fantastic resource for, again, like Greg Lehman says, kind of reconciling, and Ben's very much part of that as well, taking the research, taking the modern concepts from pain science, and putting them into clinical practice, the same as most, if not all of my speakers do. Claire Minshall's very much part of that as well. So stick around for 11:45. Ben's going to come on, which gives you 7 minutes if you need to go and do something and you want to still see it live, then go about. We've now got the function, if you want to ask a question, then a hand. You're listening to Runchatlive podcast, putting the evidence back into running injury and performance.